Hello, everyone. So nice to see you here. I'm going to share my screen. When I have the privilege of traveling around the world with Orbis, one of the things that is often asked of me is to teach goniotomy. It's an operation that seems a little bit foreign to many people, but it's so helpful. It has such great utility that we're going to talk about goniotomy and go through everything you wanted to know, but we're afraid to ask. I'm Dr. Alex Levin from the University of Rochester in New York, and I look forward to sharing this information with you. Thanks for coming. Let's start with a pretest. The first question is, and you'll be able to vote as you know, indications for goniotomy include A, goniodysgenesis, B, closed angle glaucoma, C, Peters anomaly, and D, iris bombay. Which of these do you think would be an indication? So we have goniodysgenesis and closed angle glaucoma as a tie. Let's go on to the next question. The most important thing in doing a goniotomy is making sure there's no hyperstria. 2, getting a good view of the angle. Number 3, having a Kepi lens. And number 4, making sure there's no cataract. What do you think is the most important of these things in doing a goniotomy? So make your choices. Okay, and the answers: good view of the angle, 77%. That's probably going to be a right answer later. We're going to spend a lot of time talking about that. And lastly, compared to GAT, okay, a MIGS procedure, a gonio-assisted transluminal trabeculotomy, goniotomy is faster, cheaper, easier, or all of the above? What would you say? And the answer is, wow, we got a lot of people saying all of the above. So maybe that's why you're here, to learn how to do goniotomy. So let's get on with the talk, and we're going to talk about goniotomy. What is it? It is a goniolytic procedure, essentially connecting the anterior chamber with Schlemm's canal in the face of an obstruction or a clogging, such as goniodysgenesis, the number one indication for goniotomy. It's the pros, the reasons to do it. It is very easy to do once you know how to do it. It's very fast. It literally takes me about a minute to do a goniotomy. And there's no conjunctival damage that we have with other procedures. And we know these kids often need future glaucoma surgery. The downside is you need to be able to see the angle to do it. You need some experience, and you only get one chance. It's hard to adjust once you're in the eye, and there is a small risk of cataract. As compared to trabeculotomy, ab externo, everybody has a level of comfort with raising a trab flap. You really don't need to see the angle because you're going exteriorly, and you can always combine it with a filter, the trabeculotomy, or if you fail the trabeculotomy, you can just go to a filter. So you have those options. But the downsides is it can be difficult. It ruins scleral and conjunctiva in that area that you've done your cut down. The risks are higher than with goniotomy, particularly for hyphema. Some people say if you don't get a hyphema, it won't work, and it takes longer. So for those reasons, I prefer goniotomy. There's also 360-degree trabeculotomy, which has the same conjunctival damage, where you're trying to thread a catheter or a suture all the way around Schlemm's canal. So you have to cut down to that. And if it's discontinuous, if you get a block, then you have to cut down again and cut down again. It's harder. It takes longer. It's more expensive, especially if you're using the eye-track machine, whereas using a 6.0 vicryl suture is not more expensive. And there's a higher incidence of 8-ball hyphema. Likewise, the outcomes are the same. It may save you an operation because you've got 360-degree angle open, but the outcomes, by all literature we know so far, is the same. So a harder, longer, more expensive operation with higher complications is being used. For GAT or MIGS, they're harder, especially on a soft pediatric eye. They're more expensive, they take longer to do, and they may not be available. Same with the hook dual blade. It's more expensive, it may not be available. Goniotomy is a cheap, fast, easy solution to trying to connect the anterior chamber with Schlemm's canal. And the outcomes of all these procedures when studied are about the same as goniotomy. So I'm thinking goniotomy is a good procedure. And when do I do it? Basically, whenever I can. In congenital or infantile glaucoma, where there is a goniodysgenesis, infants with Sturge-Weber who have a goniodysgenesis, aniridia when there's a goniodysgenesis, even in aphakic glaucoma following cataract surgery or pseudophakic glaucoma, if the angle has that abnormal configuration of a congenital glaucoma, it can work. Maybe another goniodysgenesis, maybe not an Axenfeld rigor. It's a little bit hard with those iris processes up there. But even in juvenile angle glaucoma, it's my first procedure. There are variants of goniotomy where instead of making a cut along, we're pushing down. We see that in aniridia when the iris starts to turn up into the angle, as we're seeing here, that iris root, we can push that down and open up a cleft in the Schlemm's. In uveitic glaucoma, it's my operation of choice, 85% success rate in an operation where you're trying to do the least amount of surgery in the eye to avoid inflammation. When do I do it? I have to have a deep anterior chamber. I have to have a clear cornea to be able to see. And if it's your first goniotomy, you want to go nasally through a temporal incision. You want to be comfortable, prepared, and a clear view of the angle is essential. Is the cornea going to be clear enough for you to see the angle? Well, ask yourself, can I see the iris detail with a slit lamp? If there is haze, is that haze epithelial edema? And of course, the more experience you have, you can go through a blurrier cornea. And when you start, you want to have a clear cornea. One way you can tell is if you take a blunt instrument and you touch the cornea and then take it away, you'll have this pitting edema, just like in an ankle of a diabetic. And that tells you that the edema is from the epithelium and could be scraped away to clarify your view. There are risks, and when you're getting informed consent, about 50% of the patients will have hyphema that rarely, if ever, needs to have anything done about it because you've just opened up a cleft for it to train to. It will fare somewhere 10 to 50%, about on average, 10 to 20% will need to have a reoperation. But it's so easy, it's so cheap that it's worth taking those chances. The risk of cataract is shown here, can be avoided by techniques that I'm going to show you. Other risks like infection, retinal detachment, blindness are incredibly rare, especially when you compare them to tubes and trabeculectomy and the general anesthetic risk. In the post-op expectations are important. About 60% of patients with any child with glaucoma, with any operation, is still going to need surgery, is still going to need medications after surgery, usually less than we started with. There's a book that we wrote that might be helpful. This is available online at www.pgcfa.org. It's a place where you can download this for free for your patients. It's in English, which may be a challenge for many of you, but it can answer every question you can think about for this surgery as well as many others. So preoperatively, I've made my decision that the patient's pathology fits goniotomy. So closed angle glaucoma, I couldn't do it because I can't see the angle. Iris Bombay, I couldn't do it because I can't see the angle. I have a goniodysgenesis, JOAG, or uveitic glaucoma. I can see the cornea. All the pieces are in place, and now we have to go and do it. Preoperatively, I may use medication for a few days just to try and clear the cornea. I might use latanoprost, COSOP, timolol. I might use acetazolamide even, just for a few days to get rid of epithelial edema to make it clearer when I get there. In some diagnoses, I want to make sure I've maximized medications before going to surgery, but if I've got a congenital or infantile glaucoma or late onset infantile glaucoma, I'm going to want to for sure do this operation rather than medications. Some people use pilocarpine to pull the pupil in, but that also narrows the anterior chamber, so I don't use that. If I'm doing it on a uveitic, I always want to do 3 days of oral steroids before surgery to quiet the eye, and I give a drop of aproclonidine 1% or brimonidine immediately preoperatively, all in preparation for the procedure. You need to have a microscope that tilts about 30 to 45 degrees from the plane of the floor. This has been done by some with loupes or an old archaic instrument, the Heine gonioscope, but a microscope is best. And the eye has to be fixated while you're doing the procedure. You don't want the eye to be turning as you're doing your cut. And we cut that, usually we do that with 2 forceps with an assistant. You want an assistant who's good at holding an eye, and you're holding the lens with the eye with a forceps, as I'll show you more detail later, and you're coming in from here to make your incision to the eye. So how do you hold the eye? Well, your assistant can use freehand 0.12 forceps at 2-point fixation, making sure to grab exactly at the limbus so the conj is not tented up. This is the best, I think. You can put your hands in any position. You've got great control. It's good for ophthalmos. The downside is you do need a good assistant, and they must be at the limbus. Sometimes it gets a little crowded with their hands and your hands, but it's easy to do. Other options, you can use locking 0.5 forceps on the muscles themselves, on the superior and inferior rectus muscle. The problem is that it's very reliable. It's easy to hold, and there's a lot more room because your hands are out of the way of your assistant. But it causes chemosis. They can slip off. You can get a subconjunctival hemorrhage, and it's difficult in a very big eye to even find the muscles because they're so far out of view. So I prefer not to do this these days. You can use custom refractive forceps shown here. They're good for ophthalmos. They don't cause chemosis, but you still need a good assistant. You have to get the episclera, and if you twist them instead of just rotating, you can actually perforate the eye. So I don't prefer these either. I like the cheap, easy to have 0.12 forceps held at the limbus. And then we use a Barcam lens. You'll see pictures of this going forward. The Barcam lens is a goniotomy lens. It has a cut edge under which the needle that you're going to do this with slides. I prefer the smallest size, the 9 millimeter, the premature size, because it gives you some ability to move around on the cornea, as I'll show you. And you just have to make sure the curvature matches the curvature of the eye. If you're not getting a good lay of the lens on the eye, you might want to go to a different size. They come with an infusion. I don't think it's made anymore. They come with self-fixation where there's a flange on the lens that you can sew to sclera. I don't do that. Just have a good assistant. I like a surgeon-held lens, either this handle lens, which is a Swan Jacob that has a handle coming up the back that you can hold, or a forceps held, which is my favorite. I take my 0.2 forceps, I put them in the 2 holes, don't lift up the lens, but it can move the lens around on the eye. Remember that the lens is needed because of total internal reflection. It'll give you a view of the angle. And it's very similar to the Kepi lens, but the Kepi lens is a non-surgical lens. That's a self-retaining lens that goes in the eye to allow you to view the angle. It is not for surgery. You need a goniotomy lens, a Barcam lens, or a Swan Jacob. So here we see the lens on the eye. You can see the cut edge over here. That's where we're going to go under that to do the surgery. These forceps are going to move the lens. They don't pick up, they don't hold the lens, they just move it with my non-dominant hand. In this case, I'm doing surgery with my left hand. I'm holding with my right. Here's a lens that's too big, right? Way too big for the eye. You can't move it around. You can see the eye's been entered here with a needle, but I've got no way to move this lens around. That's why we use the smaller lens. You can go in the eye with a knife or a needle. The Swan Jacob knife is a 2-sided blade. It's a larger entry. It needs a suture when you close. There's something called a needle knife, but I go cheap. A 25 gauge needle on any kind of viscoelastic, I use Heal-On, is all you need. And it's great because you don't even need a suture at the end of the case. And you have Heal-On available. If you get any bleeding, you can control that bleeding by injecting Heal-On during the procedure. Now you got to know your anatomy. You got to know what a normal angle looks at, so look at a lot of them. In congenital glaucoma and infantile glaucoma, we have a high iris insertion and patches, as I'll show you. There may be prominent vessels in the angle that you need to avoid. The trabecular meshwork may even be covered. Here is a view I'm going to show you. But remember that when I show you this, the cornea is invisible under your lens. Therefore, you're looking in the eye, and there's going to be a tendency for your needle to rise towards the cornea. You don't want that. I've seen the cornea perforated during this surgery. You got to keep your needle flat, close to the iris. So here's an example. Here's a Barcam lens, the cut edge. We're going to go in over here, again with a needle. You can see these patches of high iris insertion. That's characteristic of infantile glaucoma, congenital glaucoma, and we want to put our blade in right, or our needle in right above that iris insertion. That'll get us into Schlemm's canal. Here's another view. We see this high iris insertion in patches. You can see here these patches, 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 and our target is right in front of that. That's where you're going to find Schlemm's canal. Here's the other eye. Right in front of Schlemm's canal is where we're going to want to make our incision. We want the patient to be pretty much flat on the table. And the first thing we do is we set up, we put a microscope in, and we make sure we got a good view. Before you do anything, make sure you have a good view. You want to bring the child in the bed towards the surgeon, over towards the edge of the bed. The surgeon sits on the side. You may want to have a hand rest here to keep your head still, or I put my pinky on the forehead. You tilt the scope. Make sure your scope is zeroed so you have some room to manipulate once you're in the eye. The pedal of the microscope is facing you. You're going to focus on the eye, on the far iris towards the angle. So here's the position for surgery. And here's what it looks like. I've got my assistant here holding. I'm holding the lens. My needle goes into the clear cornea, as you can see, and goes across to make the procedure. This is not the view that I have during surgery because I'm looking through the microscope. It's to show you what the surgery looked like. Here's an even better picture. You can see that my thumb is on the Helon cannula. So I'm ready to inject. I'm going through clear cornea. I'm holding the lens. My assistant has 2 forceps at the limbus on either side. Now, after I know that I can see, before I do anything, before I go into the eye, I put a little Helon under the lens and put it back on the eye and set up again to make sure that I'm focused before my needle enters the eye. I want the eye in a bit of adduction towards the nose. I want to micro focus on the angle because once I'm in the eye, I don't want to be fooling around. It's a quick operation. I want to be all set and ready to go. If I still have a blurry view before I put my needle in, I can scrape off the epithelium with a 7400 blade. I can use Goniotomy or some other way. I can use a cotton swab with cocaine or alcohol. But the important thing when you're scraping the epithelium is you don't want to do this at aniridia. Never scrape. In contact lens wearers, if there's a corneal transplant in certain situations, and you never need to scrape to the limbus. You only need a window. So I take off a window. So I'm sitting over here. I'm taking this hockey stick or this rounded blade, scraping off epithelium. I don't need to take off the far side because I'm looking through the near side through my lens. I don't need to go to the limbus. That's where my stem cells are. Then I'm going to put the lens back on, view the angle again, and make sure that I've got a good view before proceeding. If the view is satisfactory, after these steps, 1, I checked, I'm cloudy, I take off the epithelium. Before that, I made sure I had the right diagnosis and the right reason to do it. Then I put my Barcam lens on. I move my Barcam lens away from me. My needle's here. I'm focused on the angle, which means this is going to be blurry over here when I go in. I'm going to go in short upgoing, about the length of the bevel, and then flatten my hand to get a self-sealing wound. If the cornea is a little tenuous and you're still getting edema, you have to make a decision. Do you want to continue or not? You only continue if you feel comfortable and you can see well. Otherwise, you convert to another procedure. And you have to move fairly quickly. Once you're in, you get in. Your non-dominant hand fixing the lens, your dominant hand has your needle or your blade, goes in, and as the lens goes in, it's going to be blurry here. You go about 1 millimeter anterior to the limbus, that short upgoing track, then flatten your hand parallel to the iris to self-seal it. And then you slide the lens towards you. And as it comes, you'll see there's a blind spot. There's a blind spot under the cut edge of the lens. That means you have to move this a little bit more towards you until you see the tip of your needle in the eye, and then can carry it forward. If you come up too far onto your needle, you'll get air. And just make sure you're not too far. Keep your eyes the whole time on the needle tip. If you just focus on that needle tip, your natural depth of field will give you everything you need to do. You're just going to be hovering over the iris as you go in. Get past that blind spot, moving the lens towards you. And when the needle's past the blind spot, stay 1 to 2 millimeters over the iris. Remember that invisible cornea. Don't drift up to that invisible cornea. You want to engage the anterior trabecular meshwork, which is usually where the iris edge is. You want to enter as deep as the widest point of the bevel on the needle. You go in one direction, to the right or to the left, and back the other way. And you should feel nothing. The only time you feel something is when the angle is very dysgenic, which happens in neurofibromatosis, in some severe congenital glaucoma and axonal rigor. Sometimes in iritis, it's a little gritty. And if you get this pigment, that means you're too far posterior and you're in the suprachoroidal space. You want to move forward, and you're going to see, do you see this white line? That line is referred to as Hunter's Trail. That line, named after a famous ophthalmologist from Orbis. Hunter's Trail is the white line that indicates you're in Schlemm's canal. Here's another view. Here the lens is being held with a finger instead of a forceps. You can see there's locking forceps, in this case on the muscle. It goes in through here. You move the lens back away now that you're in so you can see the angle. You go into the angle and just move the lens one way, then the other. This is drawn with a self-infusion lens. This is with a Swan-Jacobs knife, and you can see the same thing. I'm just cutting it open. Here again, Hunter's Trail. You can see that the iris is up here. When my blade goes in, it's making Hunter's Trail into Schlemm's canal as it goes around. You can see the iris drops back where it's done. It's a bright silvery white space, Schlemm's canal. Here we see it again. You can see the iris is up. It falls back after you have major incision. Here again, it's fallen back, and you can see Hunter's Trail right there. You follow that white line, you'll be in Schlemm's canal. Histologically, courtesy of Dave Walton, we can see the dysgenic angle before goniotomy. After goniotomy, this drops back after you make your incision. Now, your assistant has to be very good. You're telling them to move forward, back, adduct, adduct, abduct, and then you want them to encyclotort the eye and excyclotort the eye. Before they do that, you pull back your needle out of the angle, maybe about 1 or 2 millimeters, and they very slowly rotate the eye with your needle back. Then you re-engage where you left off, and you continue along Hunter's Trail to enlarge your goniotomy cleft. You could do about 120 degrees easily. You withdraw your needle or knife. There's no need to sew if there's a needle. You put Healon into the eye before coming out, and you remove the fixation without pushing on the eye. I put a lot of Healon in. It's got a place to go. You just made a big cleft. It'll go out the cleft. You don't have to worry about postoperative pressure spikes. I remove the drape. I put in some steroid ointment. I do not inject steroids. I do not inject antibiotics. Usually put some Tobradex or an equivalent in. Some people like pilocarpine. Some people like atropine after surgery. I use nothing. I just let the pupil stay neutral. If it's a uveitic glaucoma, I'll put in some apriclonidine or bromonidine. I'll patch and shield the eye. No pain management other than Tylenol is really needed. And I let the kid go home. So what were the key points? Enter a clear cornea. You may have to make the cornea clear with some preoperative medications, particularly in infants, or you may have to make it clear at surgery by scraping the epithelium. That's 75%, taking care not to invade the limbus, taking care not to do that in aniridia, not to do it in contact lens wearers, or not to do it in corneal transplants. You want to make sure that you don't look at the cornea. Just ignore it. If you look for the cornea, your needle will rise up and hit it. Keep your eyes focused on the needle point and keep it just above the iris. You should feel nothing. Feels like butter as it goes in. Only in extremely dysgenic angles when you feel something. And you should see the iris insertion drop back. Those are the key points of goniology. Number one being, make sure you can see the angle before you even start. So what happens? Let's go through some problems. What happens if it gets shallow while I'm doing the procedure? Put in some Healon. Or if you've got a syringe with some fluid on it, put that in. What you don't want to do is take your needle out, because once your needle's out, you don't get a second chance. If you're dragging iris, because the iris insertion is so high, just back off with your needle, restart a little bit more anterior so you don't drag the iris. Looking for that hunter's trail to make sure you're in Schlem's. If there are iris processes or PAS, you can just bend them with your needle and go around them. You can skip that area, go around and go to another area. What if you lose your view? Well, if it's bleed, you're not going to be able to do anything. So you want to prevent that. The minute you see a little blood coming out of the angle where you cut, put some Healon on it. If you have haberstria, you may need to move the eye and cycle to look around it. If you have a hazy cornea and you just can't see, then you may have to abandon the procedure. And if you get air on your needle, at the end of the needle that came out of your cannula, just push it out of the way with some Healon. Again, if the needle comes out, you're most likely going to abandon. Some people have tried to put in a 30-gauge cannula to inflate the anterior chamber. Usually it's shallow at that point, and it's hard to do. So doing it right is the way to get it done. If you unroof the ciliary body, as I showed, into supracoroidal space, just stop. Go a little bit, 1 millimeter or 0.5 millimeter anterior, so you get into Schlem's canal instead of the supraciliary space. If you can't rotate the eye because the assistant's forceps are getting caught on the speculum, just lean the speculum in, then rotate and lean them out. Lean the forceps in, go around, and then lean them out again, so you can get more room. So here's a haberstria. What would I do in that case? I would just rotate the eye so I can look to the right, to the left. Sometimes it's a little harder, but if you rotate around these haberstria, you'll get a view of the angle. Now, there are some variants of goniotomy in aniridia and uveitic glaucoma, as I was alluding to, or in reops. There, the movement, instead of a sliding movement, is a down push. And especially in uveitic glaucoma, the angle will just crack open on its own and go around. It'll just come across, it'll just open as you go. You want to look for that clefting. And especially with iritis, it's easy to get in the superciliary space because things are so fragile, so friable. Here we see that in this picture from Dave Walton. You can see that if you push down to open up the angle, the iris will drop back and the cleft will open. Now, if you can't see, there is another way that I'm just mentioning for interest, endoscopic goniotomy. That requires 2 wounds. Of course, you need to have an endoscope to do it. And it can't be totally white, the cornea. You have to see a little bit. Use a standard endoscopy MVR entrance with a gonio needle entrance 30 or 45 degrees away, both at the temporal limbus. You have to use Healon as you go in. You still need the eye to be fixated. The machine comes with a needle sheath. I recommend 2-handed, looks better. And you can see the angle quite nicely. Here we can see my needle is in there doing a goniotomy. You can see there's Hunter's Trail actually right up there. Here's another one, view of doing it. So that is an option, but I realize that very few places have that device. Postoperatively, I patch for 24 hours, put an antibiotic, usually gentamicin, put in some penicillin acetate. Take off the patch 24 hours, start an antibiotic 4 times a day for about a week. I start prednisolone acetate 1%, QID, or if there's a little hyphema, I'll give it 6 times a day for a week. And then I rapidly come down, BID for a week, or I taper down. I see the patient 1 day post-op, 3 to 5 days post-op, 1 week, 2 weeks. And at 4 to 6 weeks is really when you know whether it's working, and I might consider doing examining anesthesia if needed. I keep the patch on overnight. I really stress that with parents. Remember, you got a hole in the eye. You haven't sewn that shut. And if the kid is screaming and crying, you're going to raise your chance of getting a apral hyphema. Really important to keep it on. You want to use no NSAIDs. They promote bleeding. You want to use acetaminophen for pain, anti-nausea. We don't want the kid vomiting. These usually aren't problems, but you can prevent problems by instructing the family correctly. And when you're looking at, on day 1, all I care about is the anterior chamber deep? That's all I care about. And is there a hyphema? If the anterior chamber is deep, I'm fine. If there's corneal edema, that means the pressure may be high. But if I've scraped off the corneal epithelium, there's no edema because it's not healed yet. And if the pressure is high on day 1, it's just because there's blood lining my cleft. It's okay. Just use the pred and it'll go away. If there's hypotony, I want to make sure there's no posterior segment hypotony. But really, if you just are patient, you wait, you can get past these early problems. One critical thing is don't do finger tension. At least 7 days. There's a hole in the eye. There's no suture. You don't want to be burping fluid out of the anterior chamber. As I said, hyphema occurs in about 50% of patients. It really doesn't need treatment. You don't have to do anything. It'll go away out the cleft that you just made. You can increase your pred a little bit or add a steroid ointment at night. If it's elevated IOP early on, it's usually just blood or inflammation that'll get taken care of. You might add a beta blocker to get you through that early period. Spikes from the Healon are rare because there's a place for it to go. If the pressure is truly low, it means you've got a leak somewhere. It's either leaking out your goniotomy, leaking into the suprachoroidal space, but you should know that because you saw and you avoided that pigmented suprachoroidal space when you were doing the procedure. Or it could actually be going out through the goniotomy itself. You just got a great drainage through your goniotomy, which is perfectly fine. And, if the AC is a little shallow, I'm going to start high-intensity dilators, short-acting, like cyclopentolate and phenylephrine, to help push that iris diaphragm back. That can help. If it's Seidel positive, I might put a patch back on, but sometimes the patch just pushes fluid out of the eye. The main thing is to see the kid the next day. And patience and dilation and steroids, the kids will get better. I've never had to go back and do something that I can remember. These kids will get better. A flat anterior chamber, I would just patch it each day. The only time you really have to go back and do something is if you've got a wound that needs to be sewed shut. And that doesn't usually happen with a temporal approach to the nasal angle. It's more of a problem with a nasal approach to the temporal angle, as I'll show you. If there's a cataract, wait. Often the cataract will be very localized and won't spread and won't need anything. But you don't want to get a cataract. I've had 2 in my entire career. Both were mistakes on my part. One happened because I was too brave. I went in on a temporal approach. I didn't have a good enough view. I should have stopped the procedure. The other was when my needle came out and I tried to go back in and the kid with aniridia. It was a mistake. I hit the edge of his lens, both early in my career. So you can avoid cataract. You can avoid that complication. If your goniotomy fails, and by 4 to 6 weeks, you see you're not getting anywhere, you've added medicine, you still need better control, you can do a temporal goniotomy. There you're going over the nose, shown here, so that your needle is on a steeper plane. And to compensate for that, the eye has to be pulled by your assistant down in this direction, in infratemporal direction, to flatten the plane of this needle relative to the eye, so you're not pointing directly at the lens. The only problem with this entry is sometimes it's hard to get back to your starting point and get that needle to come straight out, and you can lacerate the wound with the tip of your needle, which may need a suture. I always recommend looking at the end of the case to make sure you're self-closed. Okay. What I'm going to do is I'm going to show you some videos of these procedures, and we're going to walk through a case. This is a case of juvenile glaucoma. So we have the lens on the eye. Here's my forceps holding it. Here's my assistant grabbing the limbus with 0.12 forceps. I got a clear view, and now I'm going to try and move it away so I can see that angle really clearly. So you can see I'm moving away, and now I'm regrasping. The assistant's regrasping. He's going to pull the eye away from me to show that angle. We're going to slide the lens away so I can see where I need to go. And the needle's going to come into view in a second. And I'm a little blurry where I'm at that limbus there. I can see my needle is bevel up. It's on heel on. I'm going to go up a little bit as I start, 1 millimeter anterior to the limbus. See the lens moved away. I'm going to go up. And then I'm going to lift my hand to flatten the view, move the lens towards me. There's the blind spot. Move the lens until I see it up. There's my needle in the anterior chamber. I'm going to keep my eye on the needle as I go across the. Now my assistant moved the eye away from me to show me the angle. I'm going to engage the anterior trabecular meshwork, push down a little bit. There's Hunter's trail. There's that white line. I'm going to move in that direction to open up into Hunter's trail. I'm going to go the other direction. And then, did you see my assistant had to lift their hand because they were pushing so hard I couldn't see? I'm going to pull my needle back a little bit, ask my assistant to encyclo toward the eye, and then adduct. There's Hunter's trail. I'm going to go where I started, where I left off, and go around. You'll notice over here that we've got some tenting of the conjunctiva because the assistant isn't directly at the limbus. I'm going to touch up and make sure I've got a nice clean trail. I'm in Schlem's, that's what that bright white is. Pull my needle back. He's going to excyclo toward the eye. Come around and adduct so I can see where I left off. There's the Hunter's trail. And keep going all the way around. And after I'm done as far as I can go, this is about 180 even, this goniotomy. I'm going to go back to the position I started at. So my needle straight, I'm going to inject heel on into the anterior chamber, fill it up. I'll pull my needle back, and when it comes back, you're going to see Helon come out of the wound, boop, and take the lens off quickly. You can see the anterior chamber stays very deep. Let me show you another video. This is a patient with uveitis, and it's going to show you a little bit more of the friability of the angle. Here the needle's in. You can see the Hunter's trail, that white line. I come along, right? My assistant holding the eye, again, tenting the conj a little bit too much. A little choppy, but that's okay. There's Hunter's trail. We're going to go back to the other side of where I left off. You can see the angle is not, it's not as clean in uveitis. It's often very friable. Goniotomy is all about preparation. It takes me about 15 minutes to prep, drape, and set up to make sure I can view before my needle goes in. Once my needle goes in, it's a minute procedure. Let's get back to our pretest and do the post-test answers. Indications for goniotomy include, well, goniodysgenesis is the perfect one, right? I think we're going to answer. You can get another chance to answer. Go ahead. There we go. We reduce that closed angle. And the reason is that closed angle glaucoma, you can't get in because the insertion is steep. There's peripheral anterior synechia. You can't see the angle. Now, that's not to be confused with goniodysgenesis, the high iris insertion. But that's not typical closed angle glaucoma, right? Closed angle glaucoma will be glaucoma after retinopathy of prematurity. Or in Peters anomaly, we often have closed angle glaucoma. In Peters anomaly, you can't see because you have a corneal scar. You can't scrape that scar away. Plus, you have a very shallow anterior chamber. And in iris Bombay, you've got your iris tented up. You need to have a clean view of that angle and a reason to do the procedure, meaning that fluid can't get the Schlemm's canal because of a dysgenic trabecular meshwork. The most important thing in goniotomy is making sure no hypostria, good view of the angle, having a Kepi lens, or absence of a cataract. Absolutely, that's great, 91%. You can do it with hypostria, not a problem. You just got to make it a little harder. You can turn the eye. Kepi lens is not the lens for goniotomy. You need a Barkan lens for goniotomy, or a Swan-Jacobs lens, which is essentially a Barkan lens on a stick. And whether you have a cataract or not is not important because that's behind where you're doing surgery. It doesn't affect your view. It's a risk of the surgery, but it doesn't make you not do the surgery. And lastly, compared to GAT, goniotomy is, and you got this right the first time, gang. And sure enough, we've got all of the above. It is definitely faster than the MIGS procedures. It's definitely cheaper than MIGS procedures. And it is easier in most hands once you get used to it. Is there a difference in technique of goniotomy in primary congenital glaucoma and JOAG? And the answer is no. It is the exact same procedure. JOAG is easier because the eye is good size, there's no corneal opacities, there's no corneal edema, but it's the exact same procedure. It's a little bit more challenging finding your entry point because in congenital glaucoma, you can just use the high iris as your guiding spot where to go in. But if you know your angle anatomy, you can get to the right spot. Number two, do I suture the needle wound? No, I do not suture that wound. If you go up and then flatten your hand, let me get into the screen where you can see better. Let me take off my blur here so you can see better. If you start your incision upwards and then flatten your hand and go across, that is going to give you a self-sealing wound. And that self-sealing wound is going to not require a stitch. And then you also ask, do I wash out any of the viscoelastic? No, I leave it there. So it's not a problem at all because you just made this big whomping cleft for it to drain out. Rarely do you get a pressure spike. I just leave it all in there. Even if it clouds up the cornea a little bit, it'll go away. The next question is, what is the rationale for leaving healing in? The rationale is two. Number one, to prevent hyphema. You're putting your finger on, putting pressure on the blood vessels. We know the rate of hyphema is about 50%. That is tamponading any blood vessels. And number two, it keeps things deep, which is also helpful. And again, it does not affect the postoperative IOP very much. If you've done the procedure in the right place, you should be good. What about percentage of failure? Failure rates run about 20%. I'd say 20 to 25%. But I must tell you, I see kids all the time who I did a goniotomy on 9 years ago, 10 years ago. They're on no medications or one medication. They're perfectly controlled years and years later. You know, for a quick, cheap, easy operation with a low risk, sometimes it's a great choice. And if it fails, you go on to another procedure. I highly recommend it. Let me just see here. I think I skipped one. Bear with me. How much IOP lowering do you get? You can get the pressure down from 50 to 10. I mean, you're correcting the problem. So this is a dramatic procedure that gets you good results when it works. Leaving an air bubble in the AC is also a possibility. The air bubble can also tamponade blood vessels. It can also maintain the anterior chamber. The problem is it makes it harder to see once the air bubble's in. You can see through Helon. So if you want to touch something up or there's a little blood vessel, you want to put some Helon in, remember, you can't swap syringes in the middle of the case. You got to make your decision before you go in. Am I going to put in fluid? Am I going to put in Helon? Am I going to put in air at the end of the case? Because that's what you're going to be holding in your hand as you do the procedure. And I prefer Helon or some viscoelastic. If you don't have a microscope that can rotate, that's a problem. There really is no way to do this procedure without a rotating operation. Having said that, if you use a MIGS gonioprism lens, then you could do the procedure with the lens held. It's a stick handle under the microscope, and you can put a needle in the limbus, and you can do a very similar procedure. You're essentially doing a MIGS procedure at that point that can be done. Thank you. Can you tell me the exact location? Hunter's Trail is when you are in the trabecular meshwork, right? And that is anterior to the scleral spur. That's where at the top of that iris insertion in the anterior trabecular meshwork, the scleral spur, the Stumps canal is behind that. If you leave an air bubble in, if you choose that, the air bubble goes away all by itself. It just diffuses. How long does it last? As I told you, it can last for years. And if I have excessive hyphema after surgery, I do nothing. It goes away. If I made a cleft, it should go away. The only time I've had to do something is in a case of neurofibromatosis, where it's so dysgenic, it's hard to make it go away. Let's see what I'm getting to. Do I recommend that adults with, so I don't take care of adults. Adults tend to get more of the MIGS procedures. Goniotomy is done less in adults. There's a recent paper, I think in the Indian Journal of Ophthalmology, showing that goniotomy works in adults. I'm not sure why they don't do more goniotomy. But I'm only talking about kids with glaucoma here. After cataract surgery, if the pressure is high, I would use medications first, and if medications fail, I'd look at the angle. I'd see if it's a dysgenic angle. If it looks abnormal, I might try a goniotomy. It's an easy enough operation to do. How do I compare with GAT with 5-proline and tearing off the TM? It's basically all the same question I've already answered regarding trabeculotomy. Here's a person is saying, I find the goniotomy in small consecutive cuts is technically easier. Is it less effective? I have no idea. The question is, why would I do it that way in small cuts when I can get the whole angle open? I think that once you've done it a lot and you kind of practice that full sweeping movement, you can get a lot more angle open. I think the more angle you have open, the harder it is to close as well. A little spot can close. Sometimes the iris will creep up and close the angle. Sometimes the angle will naturally just shut on its own. Sometimes it's just not enough surface area. So the more surface area you have, the harder it is to close and the more drainage you're going to get. This is a great question. What is the coupling agent I use for the contact lens? If tear gel is not available, I actually don't use tear gel. I use the Healon that's on my syringe. I put a little bit on the base of the lens and turn the lens over, put it on the eye. So whatever viscoelastic I can use tear gel as long as it's sterile. Anything ointment-like that's clear can be used to couple the lens to the eye. You don't actually need it as much to see. You need it more for lubrication so you can move the lens clearly on the lens on the corneal surface. If there's corneal edema, it means the pressure is high. In this case, can we use pre-op mannitol before the procedure? Sure, you can use mannitol. But if it's epithelial edema, you just scrape that off and avoid the mannitol. Mannitol is unlikely to clear corneal stromal edema. It's the epithelial edema you're after. So I don't use mannitol, I just scrape it off. And how do I assess the depth of needle entry into the angle? If you note your needle, the needles are all structured the same way. They go up and out, and then they come to a point. I go to the widest point of the needle, which is about half the needle bevel. If the needle comes out, what should you do? Now, that's a really tough situation. If the anterior chamber is very flat, I'm going to do nothing. And I'm going to come back another day and either try the procedure over again or do another procedure. If there's still some room in the anterior chamber, I might try and snake in a 30 gauge cannula. Remember, I'm using a 25 gauge needle, so a 30 gauge cannula will go in the wound, put a little fluid in to try and deepen the anterior chamber. But only if it's deep would I try and go back in again. The needle size or the knife size does not depend on the eyeball size. It's the same entry point either way. So that's a non-issue. And in case of post-op hypotony due to goniotomy, what should we proceed? Again, if you have a shallowing of the anterior chamber, deepen it with dilating drops, phenylephrine and cyclopentolate. If it's not shallow, it's a low pressure, congratulations, you got a low pressure. Hypotony is a good thing. It's only when there's shallowing that you need to do something. Is there any use of hypertonic saline in clearing corneal edema prior to surgery? You could certainly try that for a few days beforehand. I'm not really worried about it because I can take it off. I can take off my epithelium. I use the medications just to avoid having to take it off. And maybe hypertonic saline would help that as well. But the thing is, once the hypertonic saline is stopped at the time of surgery, the morning of surgery for the night before, you'll have some recurrence of your edema and you'll be in the same place having to take it off, as opposed to medications, which can lower the pressure a bit to help the cornea clear. And do you get good results with peds with aphakic and pseudophakic glaucoma? So glaucoma following cataract surgery is amenable to this procedure. And there are some tricks to it, and there's varying data in the literature. The rates seem to be more successful when the angle is dysgenic. It's as if it's a combination of cataract surgery plus a dysgenic angle that led to the glaucoma. Remember, we don't know what causes glaucoma after cataract surgery. So those cases tend to do better. If it's closed angle glaucoma, I'm not going to do it because I'm not going to see. If there's vitreous through the pupil, I'm not going to do it because that's going to get in the way. I'm always going to try medications to manage pseudophakic glaucoma before I would go to a goniotomy. But 9 out of 10 times, I'm going to try a goniotomy first. It's easy, it's cheap, it's quick, it's a low-risk procedure. If it fails, I can always go and do another operation, either a tube or a trabeculectomy for that disorder. So that comes to the end of our time, 1 minute, and the end of our questions. I want to thank you all very, very much for your time and your attendance. It was great to be here. Thank you to Orbis, to Andy Chen, and to Lawrence Sika, who do an absolute spectacular job at making these sessions happen. Keep going to CyberSite. It's a wonderful platform where you can find more webinars. You can find case quizzes that are posted. You can find learning content. There are courses. And in addition, there's the consult service that allows you to ask questions of individual practitioners from around the world, experts in the field, in every aspect, in genetics, in glaucoma, in cornea, in plastics, and get your responses. Join CyberSite. It's free. It's available. Make use of it. Thank you very much. Have a great day.